Good evening, officially, everyone. Thank you for joining us this evening for our monthly edition of our Mastery webinar this evening. We will be doing tonight's case presentations and a surgical panel discussions. If you are new to one of our webinars, you will note that upon joining, you are automatically placed on mute. However, we really encourage these sessions to be interactive. So we welcome any comments, questions, feedback via the chat feature or the questions feature on the panel at the right of your screen. We'll be monitoring those and asking them throughout. And if you've asked something and we haven't hit on it during, we'll probably save it till the end. We'll leave some time at the end for some just general Q&A discussions here. So I would like to introduce our faculty for this evening's webinar. We have our moderator, Dr. Bob Santrock, out of Fernandina Beach, Florida, and Duke University, and our panelists for this evening, Dr. Mindy Dayton out of Ankeny, Iowa, Dr. Kurt Relation out of Ballotine, New York, and Dr. Ronald Cho out of Trinity, Florida. This is Lauren Lefebvre with Treace Medical, and without further ado, I'm going to turn it over to our moderator, Dr. Bob Santrock. Hi, Doc. How are you?
I'm great. Thank you, Lauren. It's a pleasure to be with all of you tonight. As you all probably know, we get a big kick out of doing these webinars. They're quite fun, especially when we get questions. So I really encourage you to use that question tab or chat tab and see if we can get some interaction going. I'm joined by some great folks today, people who have been experienced in bunion surgery as well as in the Lapiplasty philosophy, and I'm hoping that we can see some interesting uses of the philosophy and the systems out of this. Of course, I've been very close to Mindy for a long time, and Kurt and Ron, we're looking forward to having more discussions with you. I noticed that we have Mindy, and Ron says he goes by Ronnie sometimes, and then, of course, to my mother, I'm always Bobby, but I don't think, Kurt, you go by Curdy, do you? I don't believe so. I doubt it. We're going to have some, yeah, I don't think so. We're just going to have some fun tonight anyway. We are consultants paid by Treace, and our opinions are our own and not necessarily those representative of the Treace Medical Concepts Incorporated. So all systems that we discuss today should be thoroughly evaluated by you and follow all of the packaging inserts and instructions before proceeding forward. Tonight's agenda, we're going to look at the procedural algorithm. This is a new interesting diagram we've put together so that you can kind of get into our heads and see how we're thinking. And then we're going to be able to be presented by the three panelists here some cases of which they are showing, and we want to focus on MTP and double fusions, the SpeedPlate, as well as the adductoplasty procedure. And, of course, time for Q&A in between as well as at the end, so don't be afraid to ask. So everybody ready? We're going to get started. So as a promise, we talked about at the beginning, one of our main things we want to introduce to you is what we call our Lapiplasty family of procedures algorithm. So all those things we just saw in the last slide is the whole family of Lapiplasty philosophy procedures. And we want to get it in our heads that a patient presents with a bunion. Of course, we know that could mean a variety of things. Somebody comes in with Bayclal bunion, it might be indeed arthritis, or it might be a complicated bunion complicated by another factor such as metatarsus adductus. So we've looked at this algorithm a couple times, and you'll see the first two colorful columns there are going to essentially give you a decision points to look at. We put MTP joint arthrosis as the first decision point because at that point we all decided in our conversations amongst scores and scores of surgeons around the country that once MTP arthritis was there, you had to make an arthritis surgery possible. So we know arthritis surgery is going to be part of the algorithm from that point forward, and then we look for the next confounding factor, which would be metatarsus adductus. You can see that that'll push you into 4 different pathways, and that will help you decide on the algorithm of where to go. So no MTP OA and no metatarsus adductus. This is your traditional Lapiplasty. And then a variety of combinations there go down there and explain to you the options that are therefore available. And the interesting thing that I'm going to immediately throw to Mindy, because we've had so many discussions on this, and I've been enlightened by her her observations, and really Paul and Mindy have given me a huge amount of benefit going forward because of where they had many cases before even Lapiplasty was invented, but the philosophy was there. Mindy, you have no hesitation of offering any pathway. You offer the right one based on what's there, because your recovery is the same, right?
That's absolutely correct, Bob. That's the beauty of the Lapiplasty philosophy and the biplanar fixation that we use, is that the stability that we're able to achieve allows me to afford that patient almost immediate weight bearing, no matter which one of those procedures on the far right column we choose. So I can go into a little bit later, but for us, just in a short nutshell, I mean, our patients are, no matter which procedure they have, they're weight bearing in their cam boot at day 4, and protected weight bearing, doing that until 6 weeks, and then transitioning to a shoe somewhere between 6 to 8 weeks, depending on the patient and their swelling, no matter what. So that makes the conversation really easy, and again, allows us the opportunity to not have to second guess what we're going to provide the patient because of the difficulty or lack thereof of the recovery.
And Ronnie, I think this is really comforting, right? We go into this, we're going to follow the anatomy, we're going to go out of this, we're going to follow the same protocol, so the decision points are only what's relative to that specific patient, and it gives us a lot of comfort, that we don't have to borrow from Peter to pay Paul. We don't have to offer the patient something they're not expecting. They're all going to get the right treatment. And is that what you're experiencing too?
Yeah, I'll admit I had a little hesitation about the discussions with the patients initially, especially as we start talking and finishing up the talks today with the adductoplasty. But lately I've been booking a lot more, and it actually is a very easy discussion. And when you just kind of lay it out to the patient and say, look, if I don't correct this, we have a higher chance of recurrence of the bunion procedure that you're already signing up for. And when you can couple that with the fact that their postoperative course from a weight-bearing standpoint really isn't changing, I think the patients, or at least the ones I'm seeing, are appreciative of the knowledge that you're showing in those discussions, and I think they really express the understanding of the necessity for the adjunctive procedures.
And Kurt, we're going to get to you in the middle here too, but just real quickly, SpeedPlate didn't change the philosophy. It just maybe gave you a tool that feels good in your hands. You're adopting this. We're going to see some cases from you.
Yeah, I've been using the SpeedPlate, and I feel like it's definitely a quicker insertion. I think it's actually easier to get them in. Makes it for a quicker surgery and smaller incision placement.
Yeah, that's always what we're looking for, is some way to increase the user friendliness of this, both to the surgeon and the patient. And so it's good to hear. We're going to see some cases here. We're going to jump right in. Mindy, we're always looking forward to hearing from you and your experience, and I think tonight's going to be even more special.
Well, thank you, Bob. First MTP fusion is near and dear to my heart. It's been a big part of my practice for a long time. And spoiler alert, you're going to see slides in a few moments with my own foot. I'm just about 4 months post first MTP fusion. So as part of this, obviously we only have an hour, and we have 3 great different series of cases. So we don't have the opportunity to go through the nuts and bolts of really using the Lapiplasty philosophy in obtaining the correction with an MTP fusion or our exact approach to a double. I'm hoping many of the people on this have already been to a master's session in person, so they've heard me talk, and this can be more just question and answer and kind of reiterating some highlights. Plug, if you've not been to a master session, I would encourage you to go. Bob does a fantastic talk on several different things, most recently on the SpeedPlates, and I do the double and the MTP talk in a lot more detail there. So jumping into this, though, with this first case, many of you are probably looking at this preoperative x-ray and you're saying, okay, you're talking about MTP and double. This foot looks fantastic. Well, we've learned over time to really, really closely assess the first MTP, both radiographically and clinically. So I'm really asking a lot of probing questions with these patients and figuring out when is their pain, where is their pain, and trying to decipher whether it's truly bump pain or joint pain, intra-articular pain, asking questions like, do you feel like it catches? Do you feel like it gets swollen? I don't have the axial here, but I'm really taking a close look at the axial x-ray. I think it's one that we tend to overlook because that can give you a lot of information regarding the joint health. And then I'm looking to see, do I see cystic changes within the head of the first metatarsal? Because what I've learned over my 16 or so years and having done a lot of first MTP fusions is the joints always look worse when you get into them intraoperatively than they do radiographically. So a patient like this, where they may be in what I call a gray zone, my approach to this patient who told me she had the catching, she had the pain in the joint, where I found some radiographic findings I was concerned with and some clinical findings I was concerned with on range of motion, is to really, in many cases, I'll review pros and cons of a TMT and an MTP with them. My personal opinion is there are very, very few cons actually of either procedure, except for if we choose a TMT Lapiplasty when the patient does indeed have arthritis. I think that can be a recipe for failure because the last thing I want to do is put a patient through surgery and give them a straight toe that is still stiff and still painful. So in this case, what I elected to do based on all of the information that I had based on clinical and radiographic findings was a first MTP fusion. This patient, like almost all of our first MTP fusions, was super satisfied, back to all activity without any restrictions. And you can see as well the significant amount of deformity correction that we're able to achieve. So in most cases, with a virgin TMT, nothing having been done there, we can achieve an excellent reduction of the intermetatarsal angle with just the first MPJ fusion.
Yeah,
So
I mean, you have literature supporting that, right? I mean, a couple papers show 5 to 8 degrees pretty consistently. As long as you get a good triplanar correction, which I know you and Paul are excellent at.
Yeah. And one thing that I will point out in this patient that we've been doing more and more often, almost pretty consistently over the past several years, is when that fibular sesamoid is in that inner space. And oftentimes, especially in a joint that has a very hypertrophic fibular sesamoid that's scarred in, if you do a fibular sesamoidectomy, that's going to really help achieve additional correction of that IM angle. And I review it again in the master's forum on the face-to-face forums, but we're getting a complete release of our sesamoid complex, which allows us to really use the triplane principles distal to proximal, just like we use them proximal to distal with the Lapiplasty to achieve that correction.
Beautiful.
All right, Lauren. And as promised, this is my foot. Don't make fun of my ugly big toenail there. But I had been suffering no significant bunion, but with pretty significant hallux limitus for years. You can see my dorsal exostosis and my dorsal bump clinically and medial bump. I'd really been restricted in my shoe gear and had found that the activities I love doing, like running and exercising, I could hardly do burpees. Well, I don't love burpees, let's say, but let me rephrase that. I hate burpees, but I wanted to do them. Mountain climbers, things like that, I found I couldn't do anymore. So finally, I decided, you can go ahead, Lauren, that it was time for me to think about fixing my foot. And here I'm pointing out some of those nuances that I kind of mentioned earlier that I'm looking for in my patient's feet. You can see that my joint truly is somewhat narrowed. I have some osteophytic lipping on the lateral aspect of my first metatarsal head. If you look really closely, there's evidence of a cyst right in the central portion of my first metatarsal head, and then you can see that dorsal bump there. And so I knew exactly what I wanted going in. I wasn't going to accept anything less from my surgeons, who were my two partners, one of which is my husband and my other partner. So they knew what I was expecting going into surgery. And that was doing something that would completely resolve my pain long term and allow me to live the super active lifestyle that I want to. So this is what I was mentioning. This is my foot intraoperatively, my joint. And you can see I had pretty significant erosion of the cartilage in that dorsal and central aspects of the metatarsal head. It's kind of hard to see on this, but there's quite a bit of articular thinning, cartilaginous thinning on the base of the proximal phalanx as well, with a lot of that extra bone growth around the periphery. And there you can see my intraoperative x-ray on the right side. So you can go to the next slide, Lauren. And this is my x-ray at 6 weeks. And this video, don't judge, this was the first time I got back onto a treadmill at almost exactly 11 weeks. And so I put this in, I'm doing much smoother work now, but even with this at 11 weeks, I've been walking on the elliptical since 9 weeks. I've been doing some power walking since 9 weeks, but this was my first attempt at running. And you can see that it's really hard to even notice any catch or hitch in my gait. And I was able to do that. And now at 4 months, I'm running without any restrictions, doing F45, back to all my high impact activity without any concerns. So that's MTP fusion. And again, with MTP fusion, I really, really encourage you all to look at these joints more closely, because I think we're doing some patients potentially a disservice by not fully assessing the joint and, quite frankly, giving them the option for a fusion. But then we have a patient like this that comes in who has degeneration of the MTP, and as Paul, not Paul, I'm usually working with Paul and talking to Paul with our patients, as Bob mentioned in one of the opening slides, that MTP DJD is one of our major initial points in our decision tree. So this patient has fairly significant arthritis of the MTP from the longstanding bunion, the failure of correction of her previous procedure. So I knew I needed to do an MTP fusion. But unfortunately, she also had a failed proximal procedure with a non-union. So, what do you do in these? Do you just revise the TMT and hope the MTP does okay? If it's a non-active patient, do you do a color? What are your options? Well, now with the Lapiplasty philosophy, you can go back, there you go, Lauren. With the Lapiplasty philosophy, we're able to fully correct both of these deformities without having to accept anything less and accept anything that is just kind of good enough like we may have in the past. And with these doubles, much like the MTP arthrodesis, we have found, and actually in the most recent JFAS publication, our paper was published, that these patients have just as high of patient satisfaction and patient-reported function outcomes with a double as they do with just an isolated MTP fusion. And here you can see at 16 weeks post-op, so 4 months, doing fantastic complete resolution of the deformity and complete pain resolution as well.
Mindy, I was at the meeting with you this past weekend and heard you give your double talk, and you got some gruff from some people in the back row about never going to fuse both joints.
Yeah, absolutely. So, there's so many things in medicine and in surgery that we do just because we think, or we don't do, just because we think they might be bad or they might be good. And so much of that is based on traditions and not evidence. So when we were preparing to perform our double study on our patient population, and we had collaborators with that, several others that had patients involved in the study as well. We were not able to find any research looking at an MTP and TMT concurrently. So the idea that surgeons say, oh, we can't do this, the foot is going to be so stiff, they're not going to be able to walk or function, really is just based on that dogma and those traditions and not founded in science. So we really have to work on changing our mindset and our paradigms. Obviously, you guys are all on a mastery webinar, so you do TMT arthrodesis pretty regularly, I would assume, and you know how well they function with a TMT Lapiplasty. So my question is, why can't we do these together? There is some, the comment I think that Bob is referencing is there's a question about, well, are you putting a lot more strain on the TMT? So is it going to be a higher instance of non-union there? And I think there was one MTP non-union of the whole patient subset, if I'm remembering correct. And if you think about it, where the big toe joint is supposed to bear the majority of the weight. So whether it's moving or it's fused, if we have the MTP fused in the appropriate position, it's functioning perfectly normal. It's functioning just like an unfused MTP without moving. And so I don't believe that we're going to see any significant increase instance of non-union proximal. Now, is there going to be some shift back to the navicular cuneiform and the TN? Possibly. I mean, time's going to bear that out, and we're continuing to watch and study these patients long term. But the reality is, what else do I have to offer this patient at 44 and for the next, hopefully 20, 30, 40 years of her life to have a cosmetically pleasing, functional, pain-free foot? And to me, this is it right now.
Yeah, the contribution you guys have given us in the literature here is very powerful. It's just remarkable to see. It was purely based in dogma where we weren't going. Mm-hmm. And, this is a incredibly well-liked surgery amongst not only the surgeons doing it, but the patients themselves.
Absolutely. And I think this is my final case. This is a very pleasant lady. So she is a virgin TMT, did not have anything done there previously, but it was very stiff as a mobile. You can even appreciate some of the arthritic changes and really that shape of that TMT joint. So going into her first surgery and subsequent surgery, we had concerns that we weren't going to be able to correct the IM enough with just an isolated MTP fusion. Our goal is always that we release and prepare the MTP first, and if we can get that IM to close down, fantastic. We plate, we close, we're out. But if we're not happy with the deformity correction in a joint like this or a foot like this, then we'll move back to the TMT so we can get the first ray straight and then be able to position the hallux into the appropriate anatomic position. Versus in the past, we would have just accepted a really wide foot still and really tried to split that difference between fusing the toe in too much abduction or leaving it too straight and having kind of a peace sign between the first and the second. So this patient subsequently went on to have, drum roll, Lauren, there we go, bilateral double arthrodesis. And she sent us actually the picture in the upper right-hand corner from her lake house because she was just ecstatic that she could get back into her flip-flops and not be embarrassed. She could walk around, enjoy her retirement and her vacation home and be pain-free doing it, which she had not been able to do in the past. And just real quick, one thought on this x-ray, because it actually came up this last weekend at the mastery, which I think is great for learning and for a webinar like this. The question was, well, she's, 8 weeks on one side, which is her left side, and 4 months on the other side. And that looks like a non-union waiting to happen. That's a comment/question. And I'm sure many of you have already seen and understand that with the biplanar plating and getting the callus healing or the secondary bone healing, we may see that soft callus hang on for some time. And sometimes I'll see it 6 months. even, and then they come back at a year and it's 100% filled in with strong calcified bone. So in our practice, if a patient presents with just a little bit of that soft callus lucency there, but the hardware is still stable, clinically they have no pain, there's no significant swelling out of the norm, no erythema, we're letting them continue on with their progression of activity as normal. On occasion, maybe we'll hold them back from high impact activities, but this is what we see in a fair amount of cases, and that's been borne out even with CT scans, that you're not going to see a fusion in these patients. I can't remember the exact numbers because I'm terrible at numbers. Bob, I think you'll probably know it, but even up to it takes about a year before we get high 90% fusion rate on CT in these patients, and at 6 months, I think it's still only like 50 or 60% via CT. So if everything's stable clinically and they're doing well, let it go. Just let it roll.
What you don't see there is the callus. That's the callus is around that joint, and it's soft, and it's not so soft. You have to have 75% calcification before you see it on X-ray. So that could be 60% calcified bone there, and you just can't see it. That's not traversing the joint; it's going around the joint. That's why it doesn't show up on the CT even early. But you have this stable union. So it's really interesting. The new approach looks different, but we have good data from the published results for both these joints.
Mm-hmm.
Mindy, these are great cases. Let's jump over to Ronnie and see what he's got to talk to us about on the I think we're talking about SpeedPlate cases. Is that right, Ronnie?
Yeah, I have a few different ones to show here, so we're kind of all over the place. All right, so we'll just get into it. Pretty obvious X-rays here. This was a 62-year-old, pretty active male. Obviously, we can all see where this one's going, where he's having pain. Clearly, this, it isn't a bunion, even though he comes to the office, and that's kind of the chief complaint that I see from my office staff is, he's here for evaluation of a bunion. Obviously, a lot of arthritic changes across the whatever's left of the first metatarsophalangeal joint with a pretty significant osteophyte. So this is a unique case for me because, admittedly, I'm still very much the traditional dorsal locking plate with interfrag screw crossing from distal medial to proximal lateral. That's still my go-to construct. This case was at the end of a longer surgery day. The operating room staff had issues with my trays for it, and my handy rep, I'm going to give him a shout out, David Stanford, was there with backup and ready to go with it. So this was one where, first one I did, and it was basically out of necessity and not wanting to wait an extra 2.5 hours. So went ahead and did everything. We were very limited, didn't even have reamers or anything, so these are more flat cuts. Did the longer revision plates for it. Really liked the construct in the operating room. Really thought everything sat well. This was a good patient, to be honest, admittedly, to be working on. He's the type of guy, good bone stock, healthy. He was going to do well either way, but nevertheless, here we are. The important part about this case is he walked into the office at 2 weeks, which is when I see patients for their first postoperative appointments, and he was in a normal shoe with his foot semi-wrapped, so he didn't listen to a word that I said. My traditional postoperative protocol for first MPJ fusion is I more or less keep patients off of their foot for about 4 weeks with a knee scooter. I let them put weight down on the foot for transfers, for bathroom meals, and a walking boot, but I really keep them off of it for about 4 weeks before I start walking them. So this was a good learning case for me because this patient did exceptionally well. He had minimal to no pain. And like I said, he really didn't listen to anything from a post-op standpoint. When I saw him at 2 weeks, I at least convinced him to go back into the boot or humor me and at least wear a surgical shoe. But he went on to heal and do really well. So it was kind of a head scratcher for me to say, well, maybe I'm able to, start walking patients earlier for first MPJ fusions, because the idea for me of allowing patients to walk immediately versus having that discussion of, well, we got to keep you off it for about 4 weeks would be kind of huge, because these are very common procedures in all of our practices. So I know a lot of the doctors on the call are a lot more aggressive with weight-bearing protocols because of that afterwards. Bob or Mindy, anything to add to that for your postoperative protocol for first MPJ fusions?
Go ahead, please.
Well, I was going to say, yeah, hopefully we can bring you over to our side.
Yeah,
you know,
indeed.
as a patient now, having gone through it myself, I mean, I was back in a tennis shoe at 4 weeks. We've actually started transitioning our first MTPs, some of them back into shoes around 4 to 5 weeks. And I can reassure you, having done so many and used that protocol for so long, that they do really, really well. And actually, I find that my patients that restrict their activity a little bit more personally take longer for them to get back to their running and their activities they want to do, because they've already started normalizing their just muscle response and their sensation by being active earlier. So I would encourage you to continue to gradually try to incorporate it. I think you're going to be very happy and pleased, as I think your patients are going to be as well.
I agree. I think that it's been a lot of years of experience that we've put together, and I think I agree. The people that have been hesitant to weight bear because of some other fear they brought with them and didn't listen to our weight bearing protocol are the ones that went the slowest. So hopefully that encourages you, and let's see what else you got.
Yeah, it's very encouraging, because I've had patients that, doing my traditional way, not listening weight bear, and I've had non-unions because of that. So that was part of the reason for my little bit more conservative postoperative protocols with those first MPJ fusions, because I have been burned in the past. But
Ronnie, I would say, and Bob said we're supposed to have fun with this, I would say that's because your large dorsal locking plate that you used.
Yeah,
well, it's a different philosophy. It really is. You have this big rigid plate preventing any kind of micro motion. It's hard to get that to heal with any motion. So, this is different. We're trying to get a little bit of motion. Yeah, so
absolutely.
Lauren, what's the next slide?
A couple of questions. Actually, before we move on, a couple of questions came in. The first is, Doc, why did you decide to use the S3 plate here? Is it just because there was a male patient, larger anatomy? What was the thought process there? And then the second question is, on the lateral x-ray, is there some potential elevation there, or is it just a radiographic projection?
We'll answer both questions. Thank you for the second. I'm going to spare you the details. I started my practice in an orthopedic office. I'm still in a more or less orthopedic setup. So my x-ray is not a traditional beautiful podiatry x-ray unit. So I tend to get more supinated views. It has been a kind of a mind trick to me to get used to. Most of my views will look elevated, and it's kind of a tough thing when I'm evaluating the bunion, so I really have to compare it to preoperative. But I tend to show a little bit more elevation with it. Clinically, he's very, in a great position and doing very well. I chose the longer plates. Once again, early in my career, I had quite a few issues with first MPJ fusions for whatever reason. I guess it was nature's way of humbling me early. But I like a longer construct in general, so I had minimal options, but I had both available, and I just said, let's go longer. Bigger is better at that time, so that's what we did.
Awesome, thank you. Next one?
Yes.
All right, so I included this case for kind of a unique reason to me, and I was curious to pick the minds of some of the people on the call if they could give me a good percentage. But looking at this X-ray, the big thing to note is there's no tibial sesamoid position, or there's no tibial sesamoid. So gauging a tibial sesamoid position would be a little bit more challenging. But I looked and done a quick literature search, and I couldn't find an exact percentage of it. It just says that it's rare. So I was curious to kind of engage the audience and maybe the panelists to see what their thoughts are, if they have any more information than I have as to the prevalence of an absent tibial sesamoid.
That's a great question. I would say, our practice is a high volume of bunions, and I've only seen it a handful of times, so I would agree it's rare. I don't know anything other than that, so maybe somebody else can enlighten us, but I agree, at least in my experience, it is very rare.
Yeah, I've seen it very rarely. So, of course, we would, it's difficult to judge, but we're going to probably look to get that fibular set point under the med head.
Sure, exactly. Yeah. And thanks for the information. I gathered basically less than 3%. So once again, if you look at the pre-op X-ray, you would see some elevation or some elevatus. I use more of the mental Seberg's index or the Seberg's index where I'm comparing kind of multiple points along the midshaft of the metatarsal before I'm gauging it. If I'm being perfectly honest, the only thing I'm really caring about from a postoperative standpoint is how is the patient doing? How's my range of motion? How are we doing overall? Because once you're out of the operating room, you can't really change it anyway unless you're going back in there. So from a clinical standpoint, I'm more in tune with just how's the patient doing overall. So this is the fixation, obviously, with the speed plates. Mindy went into good detail about her last X-ray of, possible non-union, fusion, delayed callus formation, et cetera. I've been doing these for, seemingly a while now. I've had quite a few cases with the speed plates, and this is really the level of fusion that I'm seeing at about 6 weeks, which is super impressive for this type of joint, especially considering my patients are in a normal shoe at 6 weeks routinely. So for me, this has been huge just to not have to really worry about that, because when I see X-rays, and I've had plenty of patients who have that appearance of that incomplete osseous union, you're really just kind of walking into the room and saying, like, so how you doing? Is everything okay? Because you're waiting for them to say, I have more pain, I have more swelling, and then you got to have the non-union discussion and talk about bone stimulators, possible revisions, versus if you walk in, they're like, oh, I'm doing great. You're like, yep, of course you are. I knew everything was going great. So having this kind of expedited healing has been a huge bonus to seeing postoperative patients in the office. So this is my pretty traditional construct. I probably overutilize the Aiken. I feel comfy with the Aiken. The Aiken gives me that extra millimeter or two of correction, so I'm pretty quick to pull the trigger on it. I don't do it all the time, but once again, it makes me feel a little bit safer with it. I know there had been some talks about maybe if you centralize the pull of the FHL to prevent bunion recurrences. According to my knowledge, that really hasn't proven true. But anyway, for me, it just kind of makes me feel a little bit more warm and cozy inside, so I tend to overutilize it. But this patient's doing very well. We can go to the next one.
Before we go on, there was a comment that came in, kind of going back to the tibial sesamoid, that said perhaps the tibial sesamoid is non-ossified. It would show up on ultrasound, so comment there.
Good comment. Yep, fair point.
And then in going to your construct here, are you regularly using the dual quad plating? You ever use, the dual tine, the two tine? Do you prefer the points of fixation, incision size? Any feedback there?
Sure. So I only really ever do the quad. The reason being is with older, with the early systems with the traditional plates, I've had more of the hypermobile ones where I've had, the 2 plates with 8 screws. I routinely do the intercuneiform screw, and I've had to add 1 or 2 additional screws for ones where they're still gapping. So I think about all the abundance of fixation going across there, and I just feel a little bit better about having the quad system. From an incision size standpoint, my incisions have been pretty standard across the board with it. About 4 centimeters in that area. I've found with the speed plates, I really don't have to retract really at all. Very minimal. I kind of use just my pickup to retract. I do have a fellow a lot of times, which makes these easy, but if he's not with me, then a lot of times I'm flying solo, and I would almost rather just not have a scrub tech or even a lot of times a PA, if I'm being honest, retract the skin in that area. Because of that, it's been, with the ease of insertion, it's been a lot less soft tissue handling, so I've seen better healing rates with it. I'll be the first to admit I did have a fair amount of wound dehiscences when I first started doing the Lapiplasty procedure, just because of soft tissue retraction and manipulation in that area. Once again, I'm happy to go on a limb and say I have that. Since changing this over, obviously my experience doing more cases and doing these newer implants, I really haven't had much of any, maybe a little scab here or there, but nothing too significant. I also switched over to doing more of a running monocurl suture as well, just for more of a tension-free kind of subcuticular, just to be tension-free really in that area, and that's made a big difference as opposed to doing like a horizontal mattress type with nylon.
Excellent. Thank you very much. Next one for you.
So this patient, 48-year-old male, very active, bilateral bunions, coming in for me to start with his right foot. He additionally has a tibial nail on his left side that's painful for him and wants one of the screws taken out. But his feet are pretty much mirror images of one another. I actually just saw him today. He's doing well. Additionally, with second hammer toe pain just distally at the DIPJ, but pretty straightforward there. So this is an earlier X-ray because he's still going through the process. I wanted to include this one because I don't know, maybe to a personal fault, I like to include stuff that maybe doesn't look as perfect just to talk about it. I think everybody on this call has a lot of perfect x-rays and we could all show that, but I like to show stuff maybe that's a little imperfect. Elevation here, I would say definitely. I've had a few of these. It's not everyone, but I have had a few of these. I've had some that are 3 months out and they're, much more dramatic than that. And I, once again, walk in the room and I'm ready to see some, sort of awful deformed foot with no range of motion, no issues. And those patients have had, some of the best range of motion without complaints. And a lot of those are, 3+, 2-3 years out now and doing perfectly fine. So this one I would say definitely a little elevated. He's not having really any issues that I would say for now. Now, granted, it is relatively early. He's not past the 3-month mark yet, but he's still doing very well and looking forward to doing his other side. So once again, quad plating on this. This was only this X-ray was purposely at 4 weeks just to show, even though there is a little bit of elevation there, the bony consolidation that I'm already starting to see at only 4 weeks. So the wire and the tip of the toe helped me gauge the timeline for the appointment. But 4 weeks. That's kind of what I tend to see for that. So.
Lauren, can you go back to Ronnie's pre-op on that? All right, and then the next view, or go to the post-op. So I would say, I think I'm glad you put this x-ray up, Ronnie, because you're right, he might end up being elevated, I agree, but we have to sometimes be cautious with our early x-rays because he's probably not going to be as elevated as you think he is because he's still holding that foot pretty supinated. So I bring this up for those who maybe haven't had the experience that you've had as well, that sometimes they'll see this and they will think, oh crap, it's so high, I have to go and revise it right away. But really pay attention to that hind foot position, whether they're truly loading through that medial column, because in many cases it's not nearly as high as it ends up being. And like you said, they can function very, very well. But they're holding that foot in a supinated position because it's so early yet.
And don't forget the second toe pin makes them offload the foot as well because they're hesitant to have the pin hit the ground. So I agree. You're probably going to end up with elevation to some degree, but I would bet it's half as bad as it looks.
Mm-hmm.
All fair points. All right. This is my first revision case, and I think I have a second revision case. So I ended up doing both sides on this patient. She was a very fun patient. We started with her right foot, then worked to her left foot. She had a Lapiplasty type procedure done after a trauma. She was military. She's CIA affiliated. She won't tell me much more than that. She was a very, very fun patient. I enjoyed her a lot, and we'll get a little bit into her story. But we started with the right foot, and she was one where we started with the right foot, and she was 2 weeks post-op and said, hey, can we do my left foot yet? So she's very, very tough, very motivated. I added some details on her story here. So this was one of the older cases before I started doing the quad plating. So her right foot did very well. I was using an older hammer toe implant. I am not a big fan of other hammer toe implants because they just look ugly. I hate metallic ones, but nevertheless, that's what I used. Left foot was the revision side, so I used the longer revision plating. I actually did use a graft as well to gain a little bit of length. Looking at her left foot specifically there on that radiograph, you can see the metaductus. This will lead well into Dr. Relation, his portion of this. But I am becoming, or I have become much more aggressive to look at that and say, now we need to do the adductoplasty, because the only ones that I'm seeing at this point that are having any potential issue, or maybe I'm not so happy with the x-ray, but the patient is happy with everything, are the ones with the underlying metaductus. It's just, even if you can achieve the correction in the operating room, which I think you still can for the most part, you tend to see that you're losing some of that correction. And the last thing you want to do when you're doing bunion surgery is watch that thing start turning on you, or see that tibial sesamoid position start changing on you. Part of, her x-rays aren't the prettiest ones I have in the world, but very happy patient. She did very well. 6-week turnaround really to the date. She was just getting into a shoe on her right foot, and we were operating on her left. She came in about, about 8 weeks, eight and a half weeks, post-op after I did her left foot, and she was complaining of a little bit of extra swelling. So I know her pretty good at that point. I'm talking to her, we're saying everything. She's like, well, I did just run a 10K charity. I was like, what are you doing? Get out of my office. So she was a really fun patient for me, super tough girl, but doing really well, and quick turnaround. Very, very pleased with her outcome. So this is my last case, bunion done, St. Elsewhere. I've had quite a few of these to revise within my area. Always difficult when they heal the bone, because it makes your decision just that much harder. It's kind of feels like blasphemy to open up a fused joint and cut it again. It's obviously a longer healing course. I have cheated and done more MIS distal osteotomies with these, and I've gotten away with it, and I've had others fail. Curious to see the panel after I finish this one, what they've done in these scenarios. This is one where obviously I decided to pull everything out and just kind of redo it. This ended up doing very well for the patient. Her foot, her x-rays looked good, but her foot clinically just looked really, really good considering everything that she had been through. Scar tissue, always a problem on these too, so I get very worried about scar tissue, because I've had plenty of x-rays where joint spacing looks fantastic, everything looks good, and then that thing is stiff as a board. So she did well with it. She had a little bit of, once again, dirty laundry. She had a little bit of a delayed healing to that proximal incision with a little bit of an eschar that I had to treat for a couple extra weeks. Nothing major, just a little superficial, but once again, going through the same area twice, it's a tough area to begin with. So almost an expectation for me at that point with her. But position I was very happy with. Functionally, she did very well. Like I said, clinically, her foot looked fantastic. I additionally did a hammer toe implant, one of my first experiences, I believe. I think Lauren was in this case with me. One of my first experiences with the peak implant. So Lauren was there. It was kind of funny because her and my rep David were asking me about the second hammer toe, and I think I had just a little bit of a busier day. So I was like, yeah, it's just a standard hammer toe. And then I pull up her pre-op x-rays. I was like, oh, it's definitely not a standard hammer toe. And then I'm like, oh, she already had a procedure on it as well, so I got to cut through whatever's in there when I was at fibrous union. So it was a little bit of a tough trial run for my first use of the implant, but everything went very well with it, and everything healed well. So yeah, back to the panelists. Any experience with doing, leaving that fused and going distal, besides like a first MPJ fusion, which would be an obvious choice as well, but any experience with doing like a distal met osteotomy to try to rotate and shift, or anything like that?
I think it's an excellent outcome. I think I would have done what you did. I would have prepped the patient for a later MTP fusion, because if they had good pre-op motion and no pain at the MTP, then I would have offered them what you did, but tell them that there is a chance that the joint is already damaged and it will get stiff, and that you will probably want us to fuse it if it gets stiff. And that's always the thing that's unknown is, as you mentioned, how much stiffness is going to be there from previous scar tissue. So it's really awesome to see this turned out well for you, and I think that's still the order of business I would have gone in.
Yeah, I agree. I feel like especially after being a revision case, that joint was already in a bad position for years prior to the first case, and then going on to the revision, you just don't know what the cartilage is like in there, but it looks like it has nice spacing on that post-op X-ray. But yeah, I think it looks great.
Yeah, that's awesome. We're getting down to our last series, I think. Lauren, what's next? Yeah, Dr. Relation.
All right, very good. So they asked me to talk about the 321 adductoplasty procedure. So this is actually my first adductoplasty. So this is a couple years ago now.
Nothing like starting with an easy case.
Yeah, I mean, this was a patient. She was 6 or 7 years old. A lot of wear and tear on those joints. She had basically her main complaint was that big lump in the midfoot, which I tried to capture on that lateral picture, but it was pretty impressive clinically. So you don't really know what you're going to see till you get the X-ray. So if you go to the next slide, you can see that significant midfoot arthritis there. So not only did she have the large bunion, then she had the metaductus. I'm looking at this going, oh boy, here we go. So I hadn't done an adductoplasty before, but I knew this was probably the patient to do it on if I was going to do one. Significant metaductus here, significant bunion deformity, a lot of bump pain, a lot of midfoot pain. So she came in asking about the Lapiplasty procedure. And that makes it kind of an easy discussion to go down that road. At that point, I was a little reluctant on my post-op protocol as I hadn't done one of the adductoplasties before, but I made that known to her. But midfoot fusion is midfoot fusion. I told her it would be a quicker recovery than with other systems. So go ahead to the next slide. A little bit of redundancy here. Talked about the aching if we needed it. One of the things we found was that the medium cut guy, which was the standard, was a little bit too big on her. So luckily, Treace has 3 sizes for the standard tray. But the metaductus component was a major aspect here to look at. Next slide.
Yeah, she's got like an hourglass foot, narrow in that middle section, huh? It's really wild looking.
Yeah, it really was taking a left turn there. So we can head over. Yep. So again, first time I did one of these, I was very cautious. So splint 5 days, then cam walker, but I kept her non-weight bearing. And I was checking through my notes, and I was shocked I had her non-weight bearing till like the 4 to 6 week mark. I think I told her she could start bearing weight at 4 weeks, and she waited till 6. And I saw her, and she was in the cam walker till about 10 weeks. But at 4 months, she had near complete consolidation on the X-ray. So she went back to work as a waitress. She was doing doubles at 22 weeks, no midfoot pain. And I saw her. I do have some post-op images clinically and X-rays at a year, and she's really happy. So if you want to go to the next slide, you can see the pre and post-op here. So pre-op, even at 4 months, a lot of edema. You see the fairly large incision there. That's back when I was doing like one single long incision for the first TMT and the first MTP. And then the standard adductoplasty incision there on the lateral aspect of the foot. But I was really happy with the correction, especially being the first one. You see on the oblique, it's really important to get those plates lined up directly over those joints. But what's really amazing about these procedures is when you do get your initial correction on that second and third TMT joints, you really see how big that first IMA really opens up. So it makes it that much more gratifying. And if you look at that lateral X-ray at 4 months, even if though she's only 4 months out, and all that hardware is in there, everyone gets concerned about, is there going to be prominent hardware? That's the biggest question I get from patients. Her soft tissue envelope is so much smaller than it was pre-op with that arthritic synovitis and inflammation. as well as the spurring that she had. So I was really impressed with that lateral at 4 months.
That's impressive. That's the type of case the patient will cry when they see their foot and you take the bandages off because they're like, oh, I'll fit in the shoe now, and they start to cry.
Yeah, that was one where I believe you actually did. I think I had told Matt Cleary, I think, is listening here. I did tell him about this patient, and she did actually, when I took her first bandage off, there was a tear.
But I've had it happen more than once. Yeah.
Looks great.
At that 1 year, if you go, so on the very right, that's a 1 year post-op, you really can't see those incisions at all, especially that lateral incision. And if you go to the previous slide, that's a 4 month post-op. The edema reduction is dramatic. So really, I tell all these patients, you really have to wait about a year before you know where you're going to be. And she was very happy. She's talking about having her other foot done at this point. So she's going to be giving me a call probably in the next couple of months to get the left foot scheduled.
That is a dramatic result. That's beautiful.
Thank you. So second case, so this kind of just goes to illustrate how far my post-op protocol has changed and improved over the last few years, as well as the hardware. So this is a more recent case, 53-year-old female. She came in for the bunion. As you can see, she has the metaductus there. I really like Jody's technique of the plumb line. So that makes it really easy to demonstrate to patients that they really should have the adductoplasty done. She did have some midfoot pain, which also made it an easier discussion to have. And she was pretty well aware of the Lapiplasty procedure. And you can see on the lateral, there is some arthritis there. Go ahead to the next slide. So at this point, I had just started doing the micro Lapiplasty, and this was, I believe, my first mini adductoplasty. So that made it an easier discussion with the patient as well, because I was able to get that adducto done with the 3.5 centimeter incision and then the 2 centimeter for the micro. So it really cuts down on the OR time, much smaller incision size, much less pain post-operatively, and I think the edema is better as well. Next slide. So here's some intra-op photos of my construct. So you can see I used the 2x SpeedPlates for all of the joints, and then the M1C2 screw. And you can see the position of that screw on the lateral. So I usually throw it from a plantar medial into the body of that intermediate cuneiform. So that really seems to give it that more of a 3D construct. Next slide. And then you can see the correction. I mean, the size of the incisions, these were just, because it was my first one, I had them take some photos of the actual incision size. And I was able to get that done through a 3.5 on the adducto portion, and the micro was a 2 centimeter. And then I usually go and clean the bump up immediately. So I make a small incision there and do a little capsulorrhaphy, Aiken if I need to. In her case, I don't believe I needed to. You can go to the next slide. So again, because it was the first one, I took a lot of pictures. And you can see really the swelling wasn't too bad. As she got more on it, she got a little bit more swollen, but the incisions, you see them fading already at 4 weeks. Really, really impressive compared to my first adductoplasty, where that big long incision medially. Next slide.
Kurt, did it take you longer to do it with the mini approaches, micro approaches, or
no, I don't remember the exact time. I want to say I was about 90 minutes, all the hardware in, I think. But I don't have the op report in front of me, but I believe it was pretty quick. All things considered. And I took a lot of extra time with pictures and everything too. So I move right along on these, and I think it's easier with the smaller incision, honestly, just because you're right there. Go ahead to the next. Oh, my rep just texted me 87 minutes I had hardware in for that case. So day one, they were in a splint. Because of my current practice situation, I have these patients sometimes come in next day. Usually it's 4 days. But I put it right into a cam walker, began range of motion immediately. I think that's really important, and especially with the toe and ankle, just to get them out of the boot and moving a little bit. But I had her partial weight bearing at 2 weeks in the boot, and when she came into her 4-week visit, she was full weight bearing in the boot, which I told her she could be, and no pain at all. But told me, oh, by the way, I'm walking a few steps from my bed to the desk when I have to answer emails with no boot on. So we had to have a discussion about that. That's not what you want. I explained, she really needed to be in the boot, especially with this procedure, for at least that 6 to 8 weeks. But she wasn't having any pain, and this was the 4-week X-ray, which I thought I was really happy with. I mean, you already see some early consolidation starting there on the oblique at those second and third TMTs.
Yeah, those speed plates, absolutely anecdotal information here. Across the board, we hear people say and show images that look like the healing is quicker to that consolidation. We don't have proof of this yet, but anecdotally, this is a very consistent observation, and that's very encouraging. So as we monitor these patients long term and study these patients prospectively, we'll be able to get that data out. But it's across the board. Our surgeons across the country give similar reflection: less pain, less swelling, quicker consolidation on X-ray. Again, anecdotal information today, but hopefully we'll be able to prove that out over time.
Totally agree. I do find that myself, and I find a lot less swelling and less pain with the speed plates, just comparatively to, again, that's anecdotal, but
yeah, that's what I was remarking. Mostly is the speed plate that cases, no matter the incision size.
Exactly. Yeah.
Yeah.
And I think those are my only 2 cases. Yeah.
Well, these were exciting cases, and it's really great to hear 2 new people on our panel give us their experience. And I think probably a lot of people listening can gather some information from that, it's not just the experts that get up there that have done the most cases that tell you these things. These guys are experiencing the same things we are. They're putting it in their hands. They're testing it at their own speed. And it goes to show you they're evolving as they find success. And I appreciate you guys sharing your cases, because that was excellent. And Lauren, do we have questions to follow up here?
We do. So the first one actually is going back to Dr. Troxel on his the first MTP fusion case that he presented. And the question was, and I can go back to the slide as well, but were those flat cuts or concave convex reamers? And then how often do you graft with those particular cases? So
I think you told us these were flat cuts. You didn't have the reamers available, right?
Yeah, I had a very bare bones set. I go back and forth even if I have everything available. These were more of a kind of a contoured, not like a true flat cut, because obviously you can see more of a conical shape there, but kind of using the saw to more or less do the contoured cuts. It's really all I had. I think I had like a hand tray available as well, so we were really pulling a MacGyver on this one. It was just kind of later in the day. We had already burned through a lot of the supplies, so yeah, that one was more of a saw cut.
Do you graft these?
I graft in the sense of just using like a little bit of DBM, just like a very small amount, but for the most part, it's just subchondral drilling and putting it together. A little
Do you
DBM
graft
case to make it look
in
pretty.
your other Lapiplasty family of surgeries routinely?
Pretty much just DBM for me.
DBM?
I have
Okay.
Pretty
Kurt,
much use it for
what about you? Yeah. Kurt, what about you?
Yeah, I graft on pretty much all of these. I've done several with the calcaneal autograft utilizing the fast grafter, or similar devices, and also I use a lot of like different types of bone product, like typically like the frozen bone product. I don't want to name names, but yeah, I typically graft all these cases. I feel like the ones I don't end up having just delay. It just helps fill in those gaps, to speed up the process of the healing and the consolidation on the X-ray. Maybe just makes me feel better.
And Mindy, you and Paul, most of the series you all have not been bone grafting series, but you're all adding it more and more often, just as you see some of the literature come out and the benefits that are there. You're adding that to your repertoire slowly over time.
Yeah, you're absolutely correct. We rarely do MTP fusions unless it would be like a revision where I'm taking out an implant and have a really large void. Then I'll use both structural and something like a beta-tricalcium phosphate composite graft.
I'm a big fan of autograft after reviewing the literature. I spent a year during the COVID back in my fellowship to help run that for a year. And we pulled all the literature regarding midfoot fusions that had nothing to do with Treace publications. They were all other publications, and we found a pretty consistent trend and independent analysis that would show that autografting helps prevent non-union. Now, our non-union rates are in that 1 to 2% range, so we are dealing with a very small percentage, but it takes me 2 minutes to do a fast grafter and harvest the bone and put a stitch in it. So it doesn't slow down my post-op protocol. So I've actually autographed every single surgery I do with bony fusion. So there you get the broad reach on what we're grafting and what we're not grafting. All right, Lauren, what you got?
So the second question from that same surgeon was, I've had the IM open up a couple times using the Lapiplasty on the table after fixation was applied and temporary pins pulled. Not sure why that's happening. How could I avoid that? And would a screw from the first to second metatarsal make sense there?
Oh, you got Mindy and I are both salivating to answer this. I can tell you that. I'll tell you that the most likely thing to have is your soft tissue releases weren't done. I know Mindy wants to say that weren't done complete enough. I'm not saying you didn't do them, but that's our experience. I'm going to hear from Kurt and Ron first. Have you all had this happen?
Yeah, I've seen that, especially in my earlier cases. I found that once I started using the speed release, I was able to get a much more complete release of that lateral aspect of the joint, and it really made a big difference. And if I have that issue, I never throw a first to second metatarsal screw. I've seen a couple of people come in as patients from other surgeons that have had that put in, and that's where they typically have pain. I will go M1 to C2, and I find that that's a nice stabilizing screw for the IM as well.
I agree with Kurt. I've seen pretty much the same thing. As I've done more, and especially now with the speed plates, I don't see it as often. But one of my final checks is I have everything kind of reduced with the external guide. I take a C-arm shot, kick it over, then I take it off and take another shot. You will see some apparent gapping. Just if you have the external device cranked down, it is going to be having some sort of pulling effect medially on that second metatarsal as well, which kind of can over exaggerate, I guess, your IM correction. But as long as it's not rotating, I'm happy. I don't do anything with it. If there is rotation, then I'm quick to say, all right, one more screw, and I do it from the first med into the intercuneiform.
So, Mindy, any of the tools can overpower an inadequate soft tissue release.
Yeah, absolutely.
And that's what you and Paul have taught us, is that although it's not the sexy part of the surgery putting in hardware, the soft tissue release is imperative. And meticulous.
Absolutely. I agree with everything that everyone said. And one point that I think it was Ronnie who was just talking made that I want to, is a very, very poignant, important point, is if you are over cranking that positioner down, that is going to induce a lot of abnormal forces. And when you take that off, it is likely to pop open. So it should be a nice soft touch on that positioner. I think that was such a huge point that he made. And then the other thing I just want to say is I typically I never use M1 to M2. Pretty uncommon that I use M1 to C2. I don't think it causes any problems. I just find that when I dial it in, I don't tend to need it. But the most important thing, because I learned this early on, is that if you do notice that I am open, an M1 to C2, even though on the table it might look like it closes it down, it is not going to save it. So just take the time to take everything off or out and get it right. If you want to use it as reinforcement, fantastic. No harm, no foul in that. But do not use it to try to save a less than ideal correction, because I've been burned on that one too many times early on. It will not work.
100% agree with that one. Been burned many times.
So that same kind of comment, feedback came in that they've had a similar issue, that after they remove the reduction clamp, they lose some correction, they place it on it, and it's okay until they get their medial and dorsal plate on. So I think it's just kind of reemphasizing those talking points that you had.
Mm-hmm.
Another question did come in. If you don't see, and you kind of hit on this a little bit Dr. Dayton, in your double, if you don't see any fusion in the x-ray, at what point would you consider or start to think about a bone stem? 6 months, a year, if there's pain at 6 months, if there's a visible gap on the x-ray, how long would you wait to introduce a bone stem? Of course, if there's no pain, then that's a different story. But if there is pain, when do you start to think that?
Yeah, that's a great question, and I don't have a hard and fast rule for you. The things I'm thinking about is, as you said, is there pain or not? If there's not pain and everything's stable, I usually don't order a bone stem, though there is times where maybe at the 6-month mark I might, because it just makes me feel a little better. It makes the patient feel better. It's probably not doing anything to speed it up, but it's healing in its natural course, but making them feel like it's better because of the bone stem on their subsequent visits. The pain, I'm really trying to decipher, is it joint pain, non-union type pain and swelling? Is it nerve irritation, and those are not always black and white, obviously, either. But if I do truly have concerns based on clinical and radiographic findings, then it kind of depends on the patient's insurance, honestly. 3 months, 6 months, whenever they can kind of get it. I have no opposition, to getting a bone stem if I'm in doubt. Again, I think it can make you feel better. It can make the patient feel better. And just help the process. So it's kind of a non-answer, but it's very patient dependent. I'm taking the full story into account each time. And unfortunately, of course, their insurance as well. So.
Yeah, I think for me it's 6 months because at 4 months I still trust that everything is somewhat sore and still developing, and I don't see them between 4 and 6 months. So it's going to be the 6-month mark for me. As a matter of fact, I have a patient tomorrow. I'm likely ordering a bone stem one. If she still has the pain she described to me at her last telemedicine visit, I see her in person. So I think in general, 4 months, you're on the early side. 6 months, you're probably definitively can get a pretty clear exam of what's going on. And of course, the discretions that Mindy said are all viable there. You can go earlier if you feel like you need it. Lauren, what else you got? Any other questions?
So far, nothing else. I know we're a little bit over time, so maybe if there's anything else, go ahead and type those in now. But thank all of you so much for this evening. This was absolutely phenomenal. I'm sure everyone got a lot out of this discussion, and we look forward to continuing to do these, to having these at our as Dr. Dayton mentioned, at our masters forums, continuing these incredible discussions. Our surgeons are always available for our peer-to-peer discussions as well. So any of the surgeons on this evening can be available for these, collaborative discussions. And any other final thoughts, Dr. Dayton, Dr. Troxel, Dr. Relation, Dr. Santrock?
I would just say thank you for the opportunity. And to echo what Lauren said, all of us are here to help everyone else learn from our mistakes, our experience, because it's ultimately about making sure each one of our patients get the best outcome. And it's the first time I've had the opportunity to listen to Kurt or Ronnie speak or share their cases, and I think there was some fantastic pearls and learning. So it was nice to meet you virtually. Thank you for your addition to this.
Yes, it was great to meet everybody as well. Really appreciate the opportunity to be on the webinar. Again, I feel like I learn every time I watch one of these as well. So it's great to get everyone's feedback and be a part of it.
Yeah, thanks everyone. This was great to see other cases. I think at the end of the day, a lot of times it's good to know that, we're all doing good work. We're all doing good cases, but inevitably we're going to have some that maybe don't go so well. So it's good to know that other people are out there experiencing the same thing, and then together we can kind of learn how to get better at doing this, so we have less and less of those.
Indeed, that was great. Good job, team. I appreciate everybody's time tonight. Thank you for all those who attended, and we look forward to seeing you in other webinars at the symposium and mastery courses, as well as at the society meetings. And keep sending us your cases, and we'll continue to learn together. Thank you all very much, and have a great night.
Have a great night. Thank you so much, everyone. Bye-bye.